disease. Now that changes your approach, because this is a local problem addressed best by surgery or radiation therapy. This is a systemic problem best addressed by systemic therapy such as chemotherapy. So just by putting together the database and thinking about it long term, we actually can predict behavior. So data matters. I told you about 10,000 cases. Now we can begin to put together models of predicting what would happen. And the first thing we learned was that if you looked at simple prognostics, such as significant it depends what you're looking for. In local recurrence, this is just one of my fellows, in local recurrence, the factors that predict it here are quite different from the factors that predict death from disease. So that's the next lesson, that as you look at these prognostic indicators, you have to decide, excuse me, you have to decide what are the factors you're looking at, because they will be very different. Now nomograms are the next extension of that. And we spoke briefly. Here you can see my interest in mathematics. They require large data sets, so you've got to set the database up. So as you get started in the cancer center, you'll begin a data set that may be not of great value for 2, 3, 4 years, but after that, a very great value. They require large data sets. They require significant events. You don't want everyone to die. You don't want everyone to survive. Well, we do want everyone to survive. But for the nomogram to be predictive, we need events that are both positive and negative. And we can construct nomograms in all sorts of ways. We have to know what the population is. What is the outcome that we're looking for? I described that for you. We have to identify what the risk factors, we have to put it together, and then of course we must validate it. Here's an example. And what it just says is that this line has to be very linear, because what we're looking at is that what the nomogram predicts here and what the actual event is here, the observed to expected. And the straighter that line and the tighter these confidence limits, the more precise the nomogram is. And we've done that in many patients. But what it does is we can now tell the patient, not just groups of patients, we can tell a specific individual patient what the probability of that event happens with some degree of confidence. And we want this to be obviously a small number. And here's just an example. You can put this on your Palm Pilot, you can put it on your computer, you can go to our nomograms and just look them up. High-grade deep tumor, greater than 10 centimeters, malignant fibrocystic lower extremity, age 35, 12-year sarcoma, specific probability 48. That's actually plus or minus 2%. So now we've got it for the individual patient. We can predict what the risk is for that particular entity. And we have nomograms for most diseases. If you want to look, you just go onto our website. You can look them up. We have nomograms for prostate cancer, for stomach cancer. Another example. We've validated them with data sets from, here's a European data set just to make sure that it applies to Europe. We haven't validated with an Asian data set. The nomograms can then be altered, and we can make them one histology or one site, or we can say we've survived 1 year without recurrence. Is my liability of being alive better? And of course it is. We can change them. I just had a recurrence, Dr. Brennan. What is the likelihood I'll do worse? And we can define the nomogram to do that. We can actually add biological variables and test treatment. This is another young fellow. And you can see we can have a subtype specific nomogram, just one histology and several sites. And you can see the difference between the underlying histologies, and we can make a nomogram for that. The other thing we can do is to go back almost 200 or 300 years back to the time of Hunter and begin to look at what Thomas Bayes, the Reverend Thomas Bayes, talked about as Bayesian belief networks, another mathematical model, because we've got all this data. And that looks at events and what is the dominant event in its cause. So it has the attraction that it allows you to do something that you automatically do as a physician, to use what you already know, to use inductive reasoning, but then calculate the probability that your predicted observation or your observed observation is actually real. Here's an example. It's a busy rib from our own. We just took patients with, surgeons with over 100 cases, and what you're looking for is these singular relationships. This is death from that tumor, and no surprise that the death is highly correlated with how long it takes to get a metastasis. But it's also highly correlated to the time to local recurrence. So the local recurrence is here predicting the likelihood that you'll die of disease. And of course, it's also dependent on where the site is. The people who have, obviously, retroperitoneal lesions will be more likely to die. And these other relationships are then established. Things like having a bone resected are dependent on multiple variables, whereas the factors that dominate the death from disease are these linear relationships. Now, we have a big problem in the United States. We really cannot afford the care that we pretend. And those of you who watched the news last night, essentially the Republican Congress closed the US government because they didn't like our new form of health care. And that health care looked to actually insure the 30 million people who don't have insurance in the United States. So for those of you who are feeling unhappy about living in Brunei, you live in paradise compared to us in terms of health care. So what can we do to actually afford the health care that we don't? Well, one of the things, and I've listed a number here, is this concept of self-critique. I'm pessimistic about organized medicine. You're fortunate, you've got an enlightened government changing it, so we have to begin to criticize ourselves to change events. The other thing we have to do is to actually educate the consumer. It's a terrible thought, but we tend to imply in the United States that death is an option, that it's not going to happen, it can be delayed forever. Well, that's naive in the extreme, of course. So this idea of self-critique. We did a randomized trial some years ago. This is a trial I didn't design, looking at adjuvant treatment for soft tissue sarcoma. The actual trial nature doesn't matter because it answers a question. And we showed very clearly that you could diminish the local recurrence by use of that therapy. A good observation. However, when we looked at survival, we didn't change survival. So I began to worry, what is the consequences of that? Now, you certainly don't want a local recurrence. That's a tragedy for patient and for physician. But you also have to put it in the context that you're not going to change survival. So then I became somewhat more critical. And the problem was that we, as physicians, note surprisingly, only look at the benefit. We never look at the consequences of what we do. And this was this particular trial. And one